Welcome to the Human Experience Workshop. My name is Phil Bride. This is where we explore various challenges with people facing difficult situations. My name is Phil Bride, and my guest today is Dr. Jonathan Hill. By the way, how would you like to be called during this?
John is fine.
John. Okay.
John.
Okay. Very informal, and it's going to be a discussion. But as we get started, and what I'd like to do is go over your background because it's so interesting. And
Okay.
you gave me some information. Do you want to do it?
Oh, whatever.
Let me go through it real
you go
quick.
through it, I'll
and then
add as
you'll
needed.
add. Okay, very good. So John was a cardiothoracic surgeon for well over 30 years, now retired. And he got his undergrad at UC Berkeley and then went on to medical school at USC and then general surgery residency in LA County, which I'm sure was interesting, at the USC Medical Center, and then went to UC San Diego for cardiothoracic surgery. He then entered private practice as a thoracic surgeon in trauma and ECMO, and then for 33 years. And then for 7 years, up until 2023, was the medical director of surgical services at Legacy Medical Group. Does that capture pretty much what you were doing?
Yes, although I was at Legacy until 2024.
Oh, okay. 2024.
Yeah.
Okay.
I retired.
So a little over a year ago.
Fully 2024 at 75 years old, I decided I'd had enough.
Wow. Okay. Well, that's quite a robust career. Very nice. And you were at Emanuel for much of that time.
I primarily practiced at Emanuel starting in 1983.
Oh, here in Portland, Emanuel.
Here in Portland. And basically, Emanuel was my home base until even when I was doing administrative work. Much of my duties revolved around folks who worked with it at Emanuel. So I always considered Emanuel my home base.
Okay. Yeah. Okay. And so what I have a big question. As I describe this, it's like, what the heck is a thoracic surgeon and what is ECMO?
Okay, well, cardiothoracic surgery really involves primarily anything from your diaphragm up to your chin.
Diaphragm to chin.
So okay. Your lungs, your heart, your esophagus, chest wall, all of those things. I primarily focused on heart surgery, although I did a fair amount of pulmonary lung surgery.
Okay.
And that was the great majority of my practice.
Wow.
I had sort of sideline in trauma since I had been very invested in trauma early in my training at LA County. And it always was an interest of mine. And one of my close compatriots from UC San Diego really became the director of trauma at Emanuel and really helped design and develop the Oregon trauma system, which is Dr. Bill Long.
Dr. Bill Long, he actually designed it at Emanuel.
Well, he had very interesting background because he grew up in Maryland, and Maryland had one of the first statewide trauma systems.
Oh, okay.
And he and actually his dad were very instrumental in sort of helping develop that early on. They had the first real helicopter system involving the state police. This is the state of Maryland.
Wow.
And so when I met Bill during residency at UC San Diego, he was a year ahead of me.
Okay.
He really helped San Diego County develop a true trauma system. And he was recruited to actually Emanuel by serendipity the same time I was for cardiac surgery to help develop. And that really was at the time where trauma designation for the state of Oregon began to become a thing.
Right.
John Kitzhaber was instrumental in that.
Yeah, the governor at the
and
time.
Bill helped all of his previous experiences in Maryland and San Diego to help really implement and develop a statewide trauma system for Oregon, which was basically designed to help rural hospitals, help local hospitals, and really begin to focus trauma care in select areas, because it's not anything that can be done well on the occasion.
Okay, so at what point did you join Emanuel and Bill?
Well, I came to Emanuel in July of 83.
83,
and
okay.
Bill came in the fall of 83.
Oh, so you guys were like almost right together.
Yes.
And
in fact, that was part of our plan from UC San Diego, was
to come to Portland.
Well, no, I mean, that was serendipity.
Oh, okay.
I came.
It was not your first choice.
No, I came up for a job interview.
Oh.
And really liked it, and decided that this is where I wanted to come. And I got back to San Diego, and Bill and I were talking. He was a year ahead of me in training, and then stayed on the faculty for another year, and said he had just gotten contacted by the people at Emanuel, who were really starting to focus on trauma, to come up. And so I said, well, this might work out, because we were very close friends.
Wow.
And
so
it's just one of those things that you can't predict. In fact, I once wrote a lecture on as I was finishing my residency. I was retired from cardiac surgery.
Okay.
And it was really entitled Karma, Serendipity, and Perseverance.
Karma, serendipity, and perseverance. I like it.
Well, when you think about it, that's the way a lot of life happens. And the perseverance part is maybe the most important in many ways.
Yeah, I could see that. So Emanuel Hospital here in Portland was starting to imagine or plan the trauma center,
right?
And recruited Bill,
right?
And you happened to.
I was along for a different role, but it worked out because both he and I share a lot of the common interests, not only in cardiothoracic surgery, but also in, say, the uses of those technologies in cardiac surgery, particularly cardiac bypass, how they could be applied to other areas outside, like trauma.
And so how does ECMO, the ECMO thing, ECMO, right?
ECMO.
Yeah. How does that?
Extracorporeal membrane oxygenation.
Okay.
Which
That's
really
a mouthful.
means is you take blood out of the body, the corpus. So it's extra, it's outside of the body, and you then oxygenate it. And membrane just happens to be the artificial lung, how those are function, and then you put it back in somebody.
So the artificial lung clearly outside the body too.
So you take the blood out, you go it through the machine, you can warm it, you can cool it, you can change the chemistry of it, and you put it back in somebody. And it's commonly used. I mean, it was really developed for neonates, for kids who were premature, and had a variety of, whether or not it was meconium aspiration or a variety of things that cause a death in neonates and preemies. And it was really designed and championed by a gentleman by the name of Robert Bartlett, who really became the godfather of ECMO for the United States, and in many cases the world.
Wow.
Ultimately went from UC Irvine to University of Michigan.
Mhm.
And University of Michigan really became the big center for the United States
Wow, for ECMO
for
stuff.
early on. Yes.
Huh,
And
interesting.
now it's everywhere.
Everywhere. Yeah, yeah. Okay. Thanks for explaining that. That was confusing, and I never really kind of put the pieces together. So very clear. Chin to the bottom of the rib cage
Yep.
for thoracic, and ECMO is outside the body, heart and lungs,
Right.
and blood. Wow. Okay. So what I'm particularly interested in hearing about is some of your experiences in dealing with difficult situations, difficult maybe people or scenarios, and how you coped with it personally and how you helped the people around you cope with it, because trauma is trauma. I'm sure
Yeah.
for more than just the person suffering.
Well, yeah, trauma is trauma. I mean, trauma affects families.
Yeah.
It
Oh, yeah.
affects communities,
Oh,
and that you know, practice as a primarily as a cardiac surgeon, and then in trauma and ECMO, you had to be able to sometimes separate yourself from the emotions and from the job, because it's hard work, and it's hard work when you have to talk to families
oh, yeah.
about what's happened to a loved one, either in some kind of surgery or some emergencies. And you have to be able to develop a little bit of a wall,
Yeah.
but you can't let your humanity disappear. I mean, one of the classic examples of the humanity sort of overcoming me
Hmm.
was, it's now 20 plus years ago, up on Mount Adams.
Oh,
There was
real close, right here in Washington.
There was a group from the University of Portland who had hiked in the spring, had hiked up the mountain and done what they do.
Yeah.
And as they were coming down, because it was beginning to thaw, giant boulder let loose and came rolling down the hill and struck this young gal in the back. She was at that time a 17-year-old student.
17 years old at University of Portland.
Yeah.
Wow.
First, and
that's kind of young for college too.
Well, it's 17 or 18.
17 or 18, but pretty young regardless.
Yeah, I mean, she wasn't an old gal. And luckily there had been a physician from who was a mountaineer, and he from Idaho actually, and he was able to be there on site, and they called the Air National Guard and went through all the hoopla to get permission to use the Air National Guard, because normal helicopters can't go up that high, right, in many cases.
Right.
And she was evacuated to Emanuel. And I happened to be doing trauma that day. And they brought her into the ER, and she promptly arrested.
Meaning?
Her heart stopped.
Her heart stopped.
And primarily from volume and cold, because she'd been lying in the snow and she'd lost volume from bleeding.
Oh, volume of blood.
Volume, yeah.
Wow.
And she had multiple injuries. And we ended up opening her chest and getting her heart back and all that stuff.
So you had to open her up.
Oh, yeah. But getting to this thing, and I spent hours and most of the night in the ICU with her and my nurses and my folks. And the part that made it very difficult for me emotionally was she was the same age as my daughter, basically.
Wow.
And my daughter was at college and all of this stuff. And so it was one of those times where you really had to kind of continue to refocus. and say, I got, this is this, that is that, and this is where my focus has to be right now.
So when in coping with it, you had to kind of recenter yourself on and focus on the job at task at hand.
That's
What
exactly
was
right.
starting to emerge?
Well, you anxiety. Number one, this little gal ultimately survived after months of work, both at Legacy and Emanuel, and ultimately prolonged rehab up at Harborview, in Washington.
Oh, up by Seattle.
Yeah,
Yeah.
that's a big world-renowned trauma center, and they had some specialty stuff there with the UW that we just weren't able to. Plus, her family was from Washington.
Oh, okay.
So, but things would creep in. You're going, oh, this is the same age as Laura. And this could be, and and I remember clearly that night because the priest from the University of Portland came over, and he came in to see her, and I remember telling him that if you have anything you can do, or you have any words, now's the time for it.
Well,
because I'm not sure we're going to make this trip.
So University of Portland is a Catholic college, and the priest would have been giving last rites,
right?
Which is
so, and then so you struggle. I mean, because there are times when you can put yourself in that position more than you would. Somebody comes in with a gunshot wound, let's say. They're still in dire, but I'm not going to be in many positions where I'm going to get a gunshot wound. But when you have a daughter and it's the same age and you're working on somebody, then sometimes that can be a struggle.
Wow. So the similarity between this gal and your daughter brought up all these emotions and I mean, her life is at stake, and you brought a priest in to possibly to give last rites, to give oh my gosh. And you still
have to focus on the job at hand.
You still had to focus on the job,
because you and your team are the only thing between her and last rites.
Right.
I mean, you're all she has.
Wow.
At least of this world.
Right.
So
is that like coming to terms and focusing, is that something that is like something that you could do like very quickly, or did you have to like take a few breaths and stand back? And
there are times where doing, with one of my friends who's very close anesthesiologist said,
he was a what?
Anesthesiologist.
Oh, okay.
And
anesthesiologist.
He always said, with surgery, there's always something. And
okay.
And so there are times where, you would have to go take 10 seconds or 30 seconds or to sort of stand back and say, okay, how are we going to shift gears? We now have to shift gears. And if we don't shift gears, our outcome might not be what we want.
Okay.
And so you do have to be able to sort of keep focused, but sometimes just standing back and taking a few minutes or a few seconds, and to sort of formulate a new plan.
Okay. So with this gal that was the same age as your daughter and was kind of reminded you of your daughter, a lot of similarities, and you had to step back because it was touching you. And it's like, how long did you have to just kind of step back? And did you do it with anybody else? With I mean, at the time,
you're doing it with.
I mean, the stepping back.
Yeah, I think that every nurses have to do that. Techs have to do that. everybody has to do that because, I mean, particularly nurses in the ICU become very involved sometimes with families. They're really good with families. Um, and there are times where together you'll just kind of go, okay, what are we doing here?
Yeah.
How are we going to refocus? What do we need to do? I mean, and I think that that's the advantage of over years and time and learning that all those people have great insights.
Right.
And they've, in many times, they've done this as much as you have.
Wow.
And there can't be this hierarchy of I'm the doctor and you're the nurse and da 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 da. You're there as a team, as a partnership to help people. That's really your job. And
Wow.
so you draw on their experience. I mean, I learned that very early on in LA County.
So the team where everybody could get emotionally involved because of the situation, the family, and the nurses, particularly because they spend so much more time with the family, that it's imperative to step back and work together and kind of reset and go, what's next and how should we approach this?
Right. And
Wow.
pick and use their experience, use their judgment,
their experience.
use what they know sometimes as well or better than you. I mean,
but you're the doctor.
Yeah, well, they're really good at recognizing different kinds of signs and things.
Wow.
I mean, they're so good at it.
Well, it's good to have different perspectives.
Yeah.
Yeah. So you were starting to go down and talk about, you were starting to mention, well, wasn't there another big incident at Emanuel with mountain climbing?
Oh, sure. That was early in my career. And
that was Mount Hood.
That was the Mount Hood climbing disaster with the OES students.
Oh, yeah. I remember that on the news. You spoke a moment ago about community trauma. That was all over the news and everybody was like in shock.
That was national news.
National news.
That was, if I remember correctly, it's still the second, I don't know, say largest climbing accident in the history of the United States.
Hate to ask what the first was.
You know, I don't.
I'm gonna have to look up. But second, I believe it because there were what 13 kids involved.
We're 13 students and instructors.
13 altogether.
Yeah, and of which a couple, one or two dropped out before they went up the mountain, just said they weren't going to do it. A guide, and once they got trapped up on the mountain in the snowstorm and were going into and had to dig snow caves. The next day, one of the guides and the students actually found their way out.
Yeah, I remember the story of that.
And but the rescue teams couldn't get there because of the snowstorm. They couldn't see.
You know, it was so much on the news, and we were like, because that was during a time when I was climbing too, and when it's sunny up above Timberline Lodge on Mount Hood, it's like, what's the big deal? When it's a whiteout, it's like, where am I?
Right.
And as I recall, the searchers could, the next day when it got clear out, they couldn't even find the snow caves because so much snow had piled up and buried them all.
Well, they ultimately found on a Tuesday, I think it was a Tuesday, they found a couple of people that were outside the snow cave.
Alive?
No. Well, they brought them down the mountain because at that time there had been a gentleman who was working with the Army, who had made the very famous statement, you can't be cold and dead until you're warm and dead.
You can't be cold and dead until you're warm and dead?
Something along those lines. That, yeah, you know, cold has been used for years, particularly in heart surgery, as a way of slowing people's metabolism so you could do what you want to do.
Right.
But when you do heart surgery and you make people cold, I mean, we used to make people cold all the time, and you just turn off the pump, and you, so there's no blood going anywhere. You have to do that when you were repairing people's aortic arches.
So that the aorta arches?
Yeah, the aortic arch. It's like the I-5 of your body.
Oh, the I-5 of your body. Okay.
It delivers the blood everywhere.
Okay.
And the big offshoots up here are to your head.
Yeah.
And so that if you make people really cold, it gives you X amount of time where you drop their metabolism to such a low rate that they're not consuming much in the way of oxygen. So you don't have to give them any blood.
Okay. So cold and dead may not be actually dead.
Right.
And
so
warm and dead, you're probably really dead.
So
okay. Well, that makes sense.
So that when they brought those kids down, they brought 3 kids to Emanuel. And it was chaos. It wasn't chaos, it was controlled chaos. Surgery is trauma surgery, and trauma things, it's controlled chaos. Wow. Because it is busy, it is active, there's stuff going on everywhere, but people are primarily focused and can do what they need to do on their jobs. And none of those, we tried to warm a couple of kids and it didn't work. They all those 2 kids maybe, they weren't able to survive. And it was devastating.
Yeah, because I bet the families were there.
Well, families were there, and for a variety of reasons, I wasn't involved with the families because we had decided early on that we'd have one person, one spokesman. That was Dr. Long, who was really the head of the trauma center.
Dr. Bill Long was okay,
and he was the face of it, and was the one who met with all of the press and all that nonsense.
Oh yeah.
But the thing that made it hard was all of those people, all those nurses and techs and physicians who had invested their time in trying to get these kids through something. They were, everybody was just devastated until the next day, because I clearly remember driving home in the afternoon, and I'm going in my driveway, and my wife comes out, and they said they found the snow cave, because there were still kids up on the mountain.
Oh, this was only the 3 kids that came out that were in the snow.
Yeah,
not the ones in the snow.
Not found the snow cave.
I remember seeing videos of them poking in the deep snow, looking for the snow cave.
So they found this. They found the snow cave, and they brought. And I remember I was in the driveway. My wife comes out and tells me. I just turned around, went straight back to Emanuel, because I knew that
they would be coming very quickly.
That some would be, and at that time, Bill had talked to all the other, basically heart surgeons at Providence and Good Sam at OHSU, because depending on the number of people, you were going to overwhelm the resources of any one institution.
Right. So you had all these doctors.
Bill had them all organized in the community.
Wow.
And as it turned out, one little gal came to Emanuel, and one gentleman went to Providence, and those ultimately were the only 2 survivors. The folks that went elsewhere did not survive.
Wow.
But we were actually, we had gotten a new ECMO device.
Okay.
Which means I could rewarm somebody very quickly without having to open their chest.
Oh, keep them closed up and rewarm.
Just make an incision in their groin and put in a big cannula in their artery and a big one in their vein, and we warmed her that way.
Wow.
And that was actually the first successful use of that new device, which was really a new use of the technology, or a new structure for the technology.
Huh.
And that was the first one in the country.
So, okay, besides being way interesting, tell me about, like, what did you go through during this?
Well,
And that was
again,
early in your career.
Again, it's several things happen with that. One is, again, you're very focused on your job.
Yeah.
And you're really focused this time because the day before was such a downer. It was hard day. And so now you've got
nobody was alive at
now
the
you've
end.
got second chance. And we could focus on, when I came back to Emanuel, no one had gone home. Everyone from the day before who was so invested were still there, wanting to know if they could help. In fact, we had to sort of say, we've got plenty of people here. We're going to be okay.
We need the rested ones.
But they were invested.
Yeah.
You know, you had a whole hospital invested in these kids.
Wow.
And which is remarkable, and was
a second chance. It had
a second chance.
Second chance with the group that was just found. Wow.
And so that it ended up being successful. So for the community, the hospital community, was all very positive.
Yeah.
That became something that helped us all.
Yeah.
And it frankly made a decision for me when I saw the kind of community and spirit that I could continue to be involved in for my career. That's where I ultimately made the decision that I'm not going anywhere else. This is where I'm going to be.
So how far into your career?
That was about 3 years.
3 years. Wow. So
if you look at a lot of people,
very new in your career as a thoracic surgeon, and to face a major disaster and have the
you know, it is those things that make you decide to be what you're doing. I mean, that you're going to stay. You're going to stay put. I mean, I'd had people call me wanting to know if I wanted to go back to USC, if I would want to do a couple other things, and no, I was home, so to speak.
You were home at Emanuel with the trauma and ECMO.
Yeah.
Wow. And you were one of the first to use the ECMO for the rewarming of a.
Well, for locally, yes. I mean, they'd use it in Europe in a variety of different kinds, but most of the time they had to split people's chests.
Yeah. So
that was what was neat about this new technology. Wish we didn't have to do that. And I could explain that whole tube thing to you, but that would take a while.
Yeah, we're not doing medical training. Just a little background. Background for so you yeah, go ahead.
So I mean, I think that you know, that's one of those things where you've gone from the lowest of your emotions to really elation in many ways, and it also cements your feelings about those with whom you work.
Building the teamwork and cementing it,
and how important that really is.
Wow.
I mean, there's very few team sports in medicine and surgery. You know, when you think about where you have to have a whole small cadre of people who are really, really focused. Heart surgery is one of them. Trauma is probably the other one.
Okay.
And ECMO.
Makes sense.
Those three, and they sort of intertwine in a variety of ways.
And you're right in the middle of all three.
But they are all very much team sports.
Wow. Okay. And the benefits of team sports, that of those kind of teams, is just the not just the technical support of everybody focused on a task, but the emotional support of everybody being able to take a step back and go, what do we do next? How do we deal with this? How do we deal with it personally? How do we deal with it technically?
And the emotional support afterwards.
Oh, and afterwards, the emotional support.
You know, because if you know, you're not always successful. and you share those lessons, but you share joy, you share tears, you share all those things with those people with whom you have shared whatever experience it was.
Yeah.
I mean, you
Okay. So earlier you talked about building, you have to build a kind of a wall. You kind of softened it a bit by saying a kind of a wall. Tell me more about that.
Well, you have to be I mean, number one, there's a lot of black humor in physicians and medicine, particularly in surgery.
Okay.
That I mean, and people will talk about stuff that other people are just going, oh my goodness, what the heck are these people? Who are these people? And we'll talk about it relatively lightly sometimes when it's really not light at all. And that's a coping mechanism.
Oh, okay. The black humor is a coping mechanism.
It can be a coping mechanism.
How so?
Well, I think it's part of any shared experience.
Kind of like shining a light on it.
Yeah, I mean, you know it's there. You know how hard it is, and nobody else knows how hard that is, except those people who are there.
Huh. Yeah.
I mean, nobody knows how hard that is, in except the people who are doing it with you every day.
Interesting. Yeah.
It's like anything, any other. I don't know how hard it is to be the president of the United States. I can't imagine that job. But
right, descriptions and describing something never seem to capture what the experience actually was.
Right. And so when you're dealing with things, for instance, heart surgery. I mean, heart surgery is is so commonplace these days.
Yeah.
But it didn't used to be commonplace. Even when I started, it wasn't nearly as commonplace as it is now. And every single time you did heart surgery, there was a real risk that someone was going to die. Every single time. And that that's always in the back of your mind.
Yeah.
And for those kinds of stresses, you sometimes can make light of situations.
Right.
And that's where the black humor can sometimes come in. And because everybody in the room knows the consequences of what we're all doing now.
That's interesting, because as you were saying that, I'm trying to relate to some of my experiences, and other people I've heard, and people in different situations, maybe not, that's the first time I've heard about thoracic surgery and but some of the others, like working in the woods or doing, choker setting or fishing in the ocean, deep sea fishing commercially, which are two very dangerous things to do. They joke a lot, those people, and they joke, and I'm sure it's the same. It's a coping. It's like how to deal with the fact that you, like in the woods, you could lose your legs or
more
or more. And in the commercial fishing up by Alaska, some of that stuff, you could go overboard and be gone.
Oh yeah, very quickly.
So even though I can't relate to it like you were describing, I can kind of see.
I think that's what happens.
Yeah.
You have to, you have to have an outlet for that wall.
An outlet for the wall. Oh,
you have to.
Okay.
You have to have an outlet.
Yeah.
And there's different ways that people have outlets.
Probably with people that get the situation.
Exactly right.
Yeah. Okay, because you mentioned that. Okay. Tell me a little. Do you have any other? I'm sure you have.
How many hours?
I don't want to go too long, but I'd like to hear one more. And
I can think of one that brings me a lot of joy and was really emotional for me.
Yeah, tell me.
young gal,
Okay.
3 days postpartum.
Wow. Okay.
So has a baby at home already, now has a brand new baby, has a husband.
Yeah.
She had what's called a spontaneous left main dissection.
Left.
The left main is the biggest artery that goes to the muscle of your heart.
Okay.
And if you occlude that left main, then 2/3 of the muscle of your heart are at risk. So it's an extraordinarily high mortality deal. And here's a young 30-ish gal, and this happened spontaneously.
Spontaneous.
And that
occlusion. So
is what happens is the wall, the inner wall of the artery dissects, tears.
Okay.
And pregnancy is not without risk.
Yeah.
And this is a known risk. It's extraordinarily small. But anyway, they're at she was out at one of the hospitals here that did heart surgery, and they had taken her to study her arteries, and they tried to fix her in the cardiac catheterization laboratory. It wasn't going to work, so they said she had to have emergency surgery. Meanwhile, we're all headed in to get things organized to do this surgery. We do the emergency bypass surgery.
Okay.
But in my experience, I'd never had anybody with left main dissection survive.
A left main dissection.
So I'd never had anybody who had put the blood flow of 2/3 of the muscle of their heart at risk survive. Most of this, you get a giant heart attack is what you get.
Yeah.
The muscle dies.
And the muscle.
So I knew, even though we were done and we were off of, we'd finished the surgery, that the heart wasn't going to work.
You knew it from past experience.
And you could tell by looking at it. We gave some time at it. So that I called OHSU, and because they're the transplant folks locally, and said, we've got a gal here who's going to need, potentially need a transplant. It's the only way she's going to be able to survive.
Because the heart's going to die.
Yeah, because heart's already died.
Heart already died.
Yeah, it is not going to recover.
Yeah,
there's no way. So they said, yeah, we'll take her, but you got to get her up here. So this is where the ECMO part comes in. So I called my crew at Emanuel, and they bring over our portable device. And
portable ECMO.
Oh yeah, we designed that back in the early late 80s, early 90s. So we could put it on a helicopter, we could put it on airplanes. We flew all over the Pacific
This
Northwest.
Must have been out at the Hillsborough Hillsborough Hospital.
Yeah, it was out there at
Tuolity.
So
okay.
So we put her on ECMO.
Yeah.
And we took her up to OHSU. And of course, I had gone out and talked to her husband and said, this is what we're going to have to do. We need your permission to be able to do this. And of course, here's this young man who's got new baby at home and has a toddler, if I remember correctly, at home.
Yeah.
And he is going, what
just happened?
What just happened? And what's going to happen? And he's very much deer in the headlights.
Yeah.
And so I can remember dropping him, getting the gal situated at OHSU, and then saying a few words to him. And then my team and I just left because we turned her over to OHSU.
Yeah.
And as it turned out, a few days later, she got a transplant. They kept her on support devices, and she got a transplant.
Okay.
And which was great. And we knew she had gotten a transplant, and that was great. Fast forward about a year from that, I am over at
so you didn't see her?
No, I never see her again.
Never see her again.
The only time I'd ever seen her was on an operating room table, covered up. I couldn't have picked her out of a lineup.
Oh.
You
never saw her face.
No, well, probably, but it had tubes and wires. It's not, and she got hairnet on, so you don't recognize. You're not going to recognize her.
Sure.
So fast forward a year, and I'm over at Home Depot
Okay.
with my son
Hmm.
because he needed a new water heater.
Okay.
And we're standing there looking at water heaters, and this couple walks by. And it's like a lot of other times you see people and you go, I've seen that guy before.
Oh, the guy.
The guy. I go, who? I wonder where I've seen him, you know. And he went down about 10 feet and he turned around and he comes back to me and he says, "Are you Dr. Hill?" And I said, "Yes." And he said, "I'm Mr.
Whatever
Brown."
whatever the, yeah.
And I knew instantly who he was.
Mm.
And he was with his wife. And this is the first time I'd ever met his wife, and she looked great.
Wow.
And she's out, and I tell you, I'm shedding tears in Home Depot in the water heater section of what ended up being quite an emotional. And you know, she's kind of going, "Who's this guy?" you know who I mean,
right?
And because it was really the first time we'd ever met, and yet we're meeting over how shall I say, a shared extraordinary experience.
Yes. Where
And
she was at severe risk of dying. You
Oh.
actually thought she might.
Oh, I was convinced she was.
And here she is, healthy.
And here she is. And
wow.
And you know that's why you do this job.
Hmm.
You know, you don't do it for the cash. You don't do it.
You don't do it for the money,
for
the cash.
ego. You're doing it for moments like Mount Hood,
Yeah.
for Mount Adams, for Home Depot. You're doing it because that's what really enriches you. That's what gives your life meaning. In
Yeah.
my case,
Mm-hmm.
is the all of those people who you may meet, who you've said, okay, you can now go back to a better life.
Wow.
And not everybody is 100%.
Yeah. Yeah.
But you've given them opportunity for a better life. And
that is quite amazing.
And that's why you do this job. And it's hard.
Yeah.
And you know, it's emotional, it's ups and downs. And you were so dependent on all of those people with whom you work.
So the self-awareness piece must be huge, to be just aware of what you can and where your limits are. And
yeah, I mean, you to do this, the kind of work I did, you have to have pretty strong self-awareness of who you are and what you're capable of. And you know, because you also have to be able to say, this is beyond my abilities. I need someone else to help. Or I am at a dead end here. I need someone else's input to help us do this task, whether or not that's the nurse or the custodian or whomever it happens to be, who has their life experience that can help you in that moment.
No room for big egos.
If you have big egos, you don't do very well, in my experience. I mean, it depends on how you want to define ego. I mean, you have to have really strong ego to do this kind of work. I mean, if you're going to turn off
arrogant ego,
yeah, I would agree.
Yeah,
my wife has a different term for it, but we won't say
that. Maybe it starts with arrogant name, ego. Maybe not.
Arrogant ego is right. Is exactly right. Arrogance doesn't get you very far in this world.
Yeah, yeah.
It's being an understanding of who you are and upon whom you depend. That's what gets you someplace.
Wow. This seems like a really good place to stop. Dr. Hill, John, thank you for the great descriptions and discussion about this.
Well, it's been a pleasure.
it's engrossing to hear the stories and to hear some of the stuff you've been through.
Well, if you talk to most physicians, there's always stories.
Yeah.
The flip side is we all carry albatrosses.
Yeah.
I mean, there are always things that come up 20 years ago. For whatever reason, something strikes you and you say, what could I have done differently?
Yeah.
But you carry a lot of joy.
Yeah.
And it gives you a meaning to what you've been doing the last 50 years.
Yeah. I can see it. I can see it in just your descriptions and your demeanor, how you talk about it.
Yeah.
The meaning it held. Well, with that, I'd like to wrap up.
Sure.
And
thank you. Thanks for the opportunity. It's been fun.
It has been another episode of the Human Experience Workshop.